For the last year, WFAE, with support from PBS's Frontline, has been investigating North Carolina's mental health system. And we realized that the system is so broken, so disjointed and fragmented, that we decided to name the resulting series Fractured. After 2 months of stories that you've heard on the radio, it's clear that crisis is not an exaggeration in describing the system. And the voices you hear throughout the series echo that sentiment.
There is a phrase in the legal circle, some people do life sentences and some people do life sentences 30 days at a time.
Sometimes I do it to lash out at them for something they've done to me, like being locked down in a cell 24 hours a day, 7 days a week. And that really messes with you after a while.
Frankly, we're way past canaries in a coal mine. I mean, this has been a crisis for a long time, and our healthcare system is feeling it more acutely now than ever because of the staffing challenges they're facing, but it didn't just come on the scene.
Consider this. More than half of the state's jail's inmates found incapable to proceed to trial because of mental illness wait more than 300 days for a state psychiatric hospital bed. And speaking of the state hospital, it only has 894 beds. That's if it's fully staffed. In reality, about 600 beds are actually available, and that's down from nearly 1,600 beds available in the year 2000. But the vast majority of people found incapable to proceed never get a bed. Charges are often dismissed because their stays in jail would be longer than the maximum sentence for their alleged crimes, usually misdemeanors. They're released, often only to return to jail on similar charges. Of course, this isn't just an issue for the criminal justice system. Many people living with mental illness go to the hospital emergency rooms to wait for a state psychiatric bed. Last year, such patients waited an average of 16 days in the ER, and that creates a backlog of beds needed, included for those in a medical crisis. So, there's a lot to unpack here. Our guests to help us do that are the State Department of Health and Human Services Secretary Cody Kinsley, Mecklenburg District Attorney Spencer Merriweather, Guilford County Public Defender Richard Wells, and the reporter whose work brought us here tonight, WFAE's Dana Miller-Irvin. Thank you guys for being here.
Thank you.
So, Dana, I want to start with you. Tell us about how you got the idea for Fractured and why you wanted to focus on the incarcerated population.
Well, I wanted to do something on mental health. I had just done a series on physical health. I wanted to do something on mental health. And in particular, I'm out in Morganton, where one of the state hospitals is. And I had heard stories about people who are incapable to proceed, and I'll explain what that is in a second, but are incapable to proceed. And so I'll do it now. So if by virtue of serious mental illness or a mental, maybe intellectual disability, you find yourself unable to understand the charges against you or assist in your own defense, then under the U.S. Constitution, your case has to stop. You're incapable to proceed, and you have to go to a state psychiatric hospital to have your capacity restored. So what I had been hearing about was people who were going between the jails and the hospitals, getting restored, coming back, going to jail, waiting for trial, and decompensating, that's the term, which means they get a lot sicker while they wait. Sometimes they won't take their medication. That's pretty common if you have a serious mental illness. Sometimes if they're really bad, they get put in isolation, which the American College of Correctional Physicians says please don't do that for prolonged periods because they'll get sicker, and they get sicker. And so that's how this series really started, my looking for that story. Ultimately, we ended up with John, but as you know, has now waited 5 years for a trial. He's now in Broughton. He's been in Broughton now for 6 months, for I think the third time, and he may be unrestorable at this point. He may be so damaged he can no longer be brought back. So, but to do that, I started to go and meet with public defenders around the state and say, I need access to that case. But I was also listening to their stories. Richard Wells can tell you about that. And I heard all this other stuff. Mm-hmm. And then I met with their clients, and I heard all this other stuff. And then their family members, and an entire series grew out of it.
We're going to get to those personal stories a little bit later, which I know people are really going to be interested to hear. At the center of your findings was a lot of data. You did a lot of digging, a lot of collection of information, and I want to make sure that I am saying those hard-earned numbers correctly. So there was staggering data around the number of available hospital beds for those in jail awaiting court proceedings. Your investigation found that half of North Carolina's inmates who are incapable to stand trial wait longer than 300 days, and sometimes with minimal in-jail treatment before they get a bed. So Cody, I wanted to shift to you. Can you tell us a little bit, especially from the state's perspective, what effect do these long wait times have?
Sure. So North Carolina is unusual in that we do all of our capacity restoration up until recently in state psychiatric hospitals. Many other states do this service in a number of other places, either jail-based capacity restoration or in community-based settings, if someone can be released on bond. We started a pilot recently. Actually, one of our pilot locations is here in Mecklenburg to start to try to provide that service in other places. But the impact is not just these individuals waiting for capacity restoration, which is important. The impact is that the average person who's getting capacity restoration in one of our state psych hospitals will have a length of stay twice as long as other patient who would come to us. So last week, on every day of the week, I had about 350 people in emergency departments across North Carolina trying to get access to some sort of inpatient psychiatric care. Many of those individuals likely would have ended up in one of our state psychiatric facilities. So you take those people waiting, plus you take the people who are waiting for capacity restoration, plus you compound it with the staffing challenges that we're having at all of the state psychiatric hospitals. It's a huge issue for people getting access to care. We have to address both those points, but we have to get upstream too. And there's a lot of things that we can do to prevent us ever getting to the point of having those large numbers of people needing care all at the same time.
Spencer, can you weigh in on how these long wait times affect the criminal justice system and your office?
Sure, but it's important to say that the long waits for people to basically have their capacity restored or even to get a bed, that's kind of the lesser problem. The bigger problem is that we didn't have what we need to treat the mental illness that actually led that person to the criminal justice system in the first place. That if that staffing existed, if that level of care existed, well before someone stepped foot into a courthouse or well before there was a criminal narrative written about a particular person, we would be far better off. There would be far less strain on our system. What we are faced with as criminal justice system actors, once someone who suffers from mental illness and does not have the capacity to assist in their own trial when they have been charged with a crime, it's devastating because you have that defendant who is kept waiting, who is in a log jam of getting, one, the care that they need, the defense that they have a constitutional right to achieve within our system. You also have a victim and a community that is right to expect accountability, that is right to expect that there will be something prescriptive that is offered to their community, and they're denied it, all because at the front end we weren't doing what we were supposed to do.
And how do you weigh that? I mean, how does your office weigh that? Because you have to, maybe you can see that somebody is mentally not well, but they have committed a horrible, perhaps violent crime. So how do you weigh all of that when you're going forward?
Your question had a qualifier in it and talked about the horrible stuff. We are blessed in Mecklenburg County to have a number of programs. We have for a long time had a wellness court, which for misdemeanors and for some of our lesser felonies to be able to channel people into a court system where they're not necessarily in custody and they have a lot of these things at their disposal. This gets a lot harder when you are faced with some of the most violent crimes that you will see. A lot of the most serious crimes in our office come right across my desk, and I can tell you that there is a seeming correlation between the most gory, grisly cases that you see. I can look at it and say, there's a really good chance that I'm going to have a capacity issue in this case. There's a really good chance that there's going to be a significant mental illness component to this case. And then you understand how long that case is going to take. You understand what sort of complications that you're going to have with the representation of that defendant with their attorney. And all of those things prolong the system, create many different obstacles for, again, that level of accountability as well as that level of hopefully rehabilitation. You can't get it because of just how under-resourced we are in dealing with mental illness in our community.
Can I just underscore something that Spencer said? The capacity restoration system and process looks slightly different in all 100 counties. The resources that are here in Mecklenburg County vary in a large way, and we see that play out where we will restore capacity for someone and we'll send them back to another county that's not as well resourced, and they'll decompensate faster, and it won't be the priority of the DA in that county to move that case forward, and so they end up back with us, which is another part of the problem, that variation.
Well, Dana and her team found that half of those accused of felonies waited more than 313 days in custody for a state psychiatric hospital bed, and the longest wait times were in the western part of the state. That was a case for a man named John who was featured in the first episode of Fractured. He waited years for a hospital bed, and Dana spoke to John's stepfather, Eric Weatherspoon, about the frustration of that wait.
I'm pretty angry. He's been gone 4 years, and they still haven't got a trial for him. You know, I can't understand it. I can't put my hands around it. The system is so messed up. I don't understand that. How you can put somebody that needs mental care, you can lock them up.
He also went on to say that he felt like his stepson had been thrown to the wolves and that nobody cared. So, Richard, I wanted to turn to you from a defense attorney's standpoint. Can you talk about what it's like to know that your client isn't getting the care that they need and not putting their best foot forward?
Well, first of all, I'm going to mention that I'm not the public defender of Guilford County. That's my boss, John Neiman. I'm an assistant under him. But it's very frustrating. You go to the jail. Oftentimes you're meeting with somebody who's severely mentally ill. They're wearing a red jumpsuit in Guilford County, so they're in a separate facility from a separate pod from a lot of the other inmates. Even though there's glass, sometimes there's a smell that comes through. There's a lot of crying and clanging and things that are going on there. And across from you is somebody who is clearly mentally ill. They may have done something really bad, or they may have simply just trespassed at the hospital. They kept going back trying to get treatment. And so I would say it is very disheartening, and you just look at the person across from you and think, this is not somebody who needs to be in jail. They need to be in a facility where the people they see regularly are doctors, not jailers. So from a personal standpoint, that's the way that it makes me feel. I'm not sure if that answers
And
your
then
question.
from a professional standpoint, I mean, I imagine that makes it very hard to do your job.
No, you wind up with you develop a skill set where there are certain things you can do to get the ball moving, to get things rolling. When you walk in and you see something like that, one of the first things I'll do is I'll go and talk with an assistant district attorney on the case and let them know that I think this is a mental health case. Can I see the police reports? Because quite often they'll shed light on what happened. You try to get an evaluation done, hopefully locally, because you can get those moved much more quickly. And then perhaps try to get an involuntary commitment done. But the way the timeframes are working now in Greensboro, Guilford County, probably the best, you're probably looking about, 4 months from when you first meet with your client until they're actually in a hospital where they're getting the treatment that they need. And during that time period, they may be picking up other charges. There are certain charges that I think we look at and we realize, well, this one's probably mental health related. We quite often see a lot of felony charges for throwing urine and feces on jailers, and quite often, I would say almost always, those are mental health related charges. So it makes it difficult for you to do your job, but there's a path forward. And I found overall our DA's office has been really good at working with us, as has our jail, on trying to move their cases forward. But to echo something that both of the other folks just said, is the problem is upstream. If there was better help on the streets, we wouldn't have people that are in jail for this.
I was thinking that accessibility to your clients might be exceptionally difficult if they're dealing with a mental health issue, and there are issues with behavior, and then they're put into isolation. Does that impact your ability to see someone?
It does. You go visit folks who have mental health issues, and quite often they refuse to come. I usually try to wave the jailer down, say, hey, what's going on with him? And hopefully they'll let me know a little bit so that I have something to work with to show that he's not just mad at all lawyers, that there's something mental health related. But our jail, we're fortunate in that we can walk across the street from the courthouse and get into the jail fairly quickly to see our clients. There's a good bit of meeting space there. There's no obstacles put up as far as that goes. But it can take a while to develop these cases as far as moving the ball forward, getting up with family members, because if the client doesn't want to talk to you, how do you get up with the family members? How do you find out they have a mental health disorder? In order to do involuntary commitment on someone, you have to know that they have a mental health defect, so you have to know a diagnosis. Getting records, all that takes time. So it takes time, but you can get in and you can see your clients and you can get the ball moving forward.
Mm-hmm. What resources, and Dana, I'm going to start with you, what is available to people if you are incarcerated, if you do have a mental health issue? I mean, what help is there for you?
While you're incarcerated? Well, it depends on what the jail offers, right? So people who are incarcerated, if they had Medicaid, they don't have access to that Medicaid while they're incarcerated, right? So what we have found, I think we were able to talk about this from a study by Dr. David Rosen at UNC, and he found that 76% of North Carolina jails offer telemedicine, but what they do is they offer a median, I think it was, of 2.5 hours per week per 100 inmates. So that's not very much.
Cody, do you want to weigh in, Spencer?
So I think we need to step back and think about the need. So 40% of people in jail or prison have a history of mental illness. 60% of people in jail or prison have a substance use disorder. So thinking about that in the context of Dana's availability of care, it's woefully insufficient. We have invested $30 million over the last 2 years to provide pre-arrest diversion, jail-based treatment, and reentry services in jails. It's pretty much to any sheriff that will raise their hand and say, yes, please. And we are currently in 40 counties. This is specifically focused on substance use disorder. And we've been able to serve in that period of time 10,000 people, which is great and hopeful, but put that in the context of, in 2019, 128,000 North Carolinians went through jail. We still have a long ways to go, and it comes back to the basic premise that Dana touched on, which is that until there's stable and steady funding to provide behavioral health services in jail and other health services in jail, we're going to have this problem. And of course, I will echo my colleagues, and we have to get upstream too and prevent from getting into jail in the first place.
Yeah, and I was wondering how much of that is 1 year funding.
It's all 1 year funding. It's not recurring. This has been grant money that we've been able to repurpose from the federal government.
Right. So, yeah.
So a temporary solution, it sounds, yeah. Mm-hmm. So let's say someone gets out. They've either served their time, or the charges have been dismissed because so much time has gone by. They've served the maximum sentence. What challenges are facing them immediately when they walk out of that jail? Dana, I'll start with you.
Well, so I did the story about Mr. Muckenfuss. He's Mr. Wells's client. You called me about him when I don't know if you remember this, but when you first called me, I said, and you told me he was out of jail. I said, I don't think he really qualifies for this series. But I went and I met him. You told me to go meet him, so I did. And it was astonishing because here's a guy, he's schizophrenic, he's a substance abuser, and because many people with serious mental illness do self-medicate. And on top of that, he's a self-harmer. So when he's in jail, he's swallowing razor blades and ballpoint pens and anything he can find, basically, right? And he told me he'd had 17 endoscopies and 2 major surgeries while in jails to have stuff removed for him. And now he's out, and he can't afford his medication. He's rationing his medication, which keeps him from hallucinating. He's getting, he didn't qualify for Medicaid, right? But he is getting 10 minutes a week of telemedicine, mostly for medication management, and that's it. Well, I listened to this story, I thought, this is crazy, right? And I thought, he must be wrong, right? Health policy reporter, he must be wrong. So I had him get on the phone, and I got on another line, and I had him call his LME-MCO, the folks who organize the care, his provider, his Social Security office. And I had him say to them, who is there out there who can help me figure out a medication solution for me in terms of payment? First of all, the answers, he wasn't crazy. He wasn't wrong. The answers were, that is, he didn't have access. But what was astonishing also was it was so complicated and confusing. And I like to think of myself as an educated person, and I'm thinking to myself, how does someone who doesn't have a high school degree, who's experiencing psychosis, and who's just spent most of his adult life behind bars, ever going to get through this? It's just ridiculous. So that became a story. And sadly, I'm sorry, I should have mentioned this, and sadly, as you know, Mr. Buckenfuss didn't make it. He died before the end of the series. I mean, before the end of the story, actually.
And was he incarcerated at the time of his passing, or was he out? He was out.
No, and that's what was so sad. He really, really, really was trying to make it. He had gotten himself a job. He was looking into getting his GED. His mom told me he was happier than he'd ever been, but he must have started to take drugs again because he did overdose.
I want to
Sure.
jump in on one thing, because the question had to do the immediate concern when you get out of jail, which is something that I see on the front lines all the time. And our jail will give a person a 5-day supply of medications, and every once in a while I can try to up that to 7 days of medication. It gets called into a pharmacy. Depending upon when you get released at night, every once in a while something gets missed so that it doesn't get called in. So somebody has to follow up with that. But that supply of meds is for 5 days. And then the time that it takes to get in and get into, you're referred to a local provider on the outside, to actually get in and get the appointment and maybe get medications can sometimes be 2 weeks, 3 weeks out. A lot of this is anecdotal from what I've heard from my clients. And so you've got, as Dana talked about, you've got this, you wind up rationing medications, you're trying to do what you can. Sometimes the clients are using street medications to try to make ends meet. They're trying to do it, but it's just very difficult, and they have high school, sometimes at best, a high school diploma, that level of education, and it's hard for me to understand as an attorney how to navigate the system. So it's hard to get out. You leave jail, you might have 5 days worth of medications, you're trying to find a roof over your head, and then you're trying to find proper mental health care on the outside, and that can be almost impossible.
Well, Spencer, I wanted to turn to you and ask, how much more likely, do you all have a sense of how much more likely someone is likely to reoffend if they are suffering from a mental illness? So they've just been in, maybe they got the care they needed, maybe they didn't, maybe they're working with just the 5 days of meds when they get out. How much likely are they to reoffend?
I think the appropriate way to classify that is just by the level of risk. You don't exactly know what that demonstration is going to look like, whether it's going to look like a crime that meets every element. I don't know. It very well may look like something that reflects instability. You know, I'm sitting here thinking about what Dana just described and what Richard just described as far as the difficulty in making sure that someone's going to get the medication that they need, all of the obstacles that they have to face. And I don't have an opportunity as a prosecutor to sit down and talk with someone who's been charged with a crime in the same way that someone who's a criminal defense attorney can. But I am talking to the victim. And the promise that I try to give to them is that, no, it's going to be okay. There are people working on this. It's going to get handled. This person is going to get released, and I know that scares you to death. But understand there's some things in place that are going to make sure that they get their medication and it's going to be fine. And that ain't true. As a matter of fact, it's very far from true. The real promise, the real candor that I can offer is that there's a great level of instability here, and I don't know. Which leads me back to the original point of we all wish that there was something more that we could be promising the community, that we could be promising the person who's been charged with a crime, that we could be promising certainly victims. And we're not there right now. This becomes something that's especially grave with some of the most serious crimes that are charged in our county. We've got a ton of folks who are in on first-degree murder cases who have collectively thousands of days that they have remained in custody as they seek to try to establish capacity, or where they vacillate back and forth between being medicated when they go to a mental institution, but when they come back, time for trial, things do decompensate and they aren't finding the medication that they need. Well, at some point, under the law, we sort of say, well, we've reached that point where we've got to make a decision about whether this person stays in custody. And should that person get released after allegedly they killed somebody, I got to go back to that victim. And I can't promise them a lick of stability because that's the system that we're in right now.
I mean, this is what is so heartbreaking to me and should be to all of us, which is that for as bad as we are describing the level of care for behavioral health services in incarcerated settings, it is worse in community. It is much harder to find people care because of, first and foremost, because we have had, for the last ever, 1.2 million people in North Carolina without health insurance.
That's right.
And poverty and mental illness are often co-occurring. And this is why we have been fighting so hard to get Medicaid expanded. And this is why I need the legislature to hurry up and pass a budget so I can expand Medicaid to begin to try to fill this gap. But I just want to be clear that we are making up for a past sin here where we have never treated behavioral health like on equal measure with health broadly, and we have never prioritized it as part of primary care. And we've got to rebuild that entire system from the ground up in North Carolina.
And I promise we will be getting to Medicaid expansion.
I'll probably say it 4 more times, so if you're...
Can I add one thing?
Go on,
which
Dana.
is, at least as of 2017, as of the most recent data, our private insurers in North Carolina also underfunded underfunded mental health in comparison to how much they spend on physical health. And our private insurers were worse than most of the rest of the country as well.
There was one individual featured in episode 2, I believe, Miguel Maldonado, who's caught in this cycle that we are talking about right now, incarceration, coming out only to end back in. And this is what the Chief Becky Cothran of the Gaston County Jail had to say about him in particular.
Mr. Maldonado is very famous to all our detention officers. We all know him. There are a lot of people that become, I would say, almost like family, like they're at the house when they come here.
That was so interesting to me, Dana, when I heard that line, family, and just the regularity of seeing some of the same folks. How did that strike you as you were reporting out this series and you heard some incarcerated folks being described that way as family at some of these jails because they were there so frequently.
Well, I mean, realistically, a lot of these people don't have family anymore, right? So their family members may have tried and given up, and after a while they just burned out. And so sometimes I wonder if when they come back to the jail, it is possibly even a relief to them. I don't know that. I will say that about when I talked about going around and talking to different public defenders, it was in Gaston County that the public defender said that line about some people serve life sentences 30 days at a time. And when I heard that line, I thought, I said to him, I said, you do know that has to be a story now, right? Because it was so shocking to me.
Yeah. And Richard, has that been your experience with your clients that I know that wasn't you that said that, right, but that, you know, some folks do serve a life sentence 30 days at a time. And do you hear truth in that?
Yes. I first will say I handle primarily major felonies, although some of my clients have minor charges as well. But I didn't always do that. And we would see folks who we called frequent flyers. I will say that I almost never have seen anybody who's in jail and says, thank goodness I'm home. I mean, people don't want to be there. You can't sleep there. There's clanging going all around all the time. Even my homeless folks, a lot of them have a tent that they consider a home. They don't want to be there. But that is true. We see cases where, and this is one that I know some of my coworkers wanted me to mention, is we get trespass cases at the local hospital where people are going for mental health treatment. Why? Because they said, look, you can't do anything else for you. You need to leave. You're taking up space. Something along those lines. And so they wind up getting charged with trespassing, and then they wind up going down to the jail, and they will spend 20, 30 days until they've done more time than they can get, and then they're released. And so that does happen. There's a ring of truth to that.
Spencer, do you want to weigh in on that?
There's not a lot of distance between that problem than something that we also see locally, where they're with young people who are suffering from varying levels of mental illness, who parents have reached a point where they just don't know what to do. Drop a kid off at a hospital. There are varying levels of diagnosis that those children receive, and the hospital says, all right, you're good to go. And parents don't necessarily want to pick the kid up because they don't know what to do with them next. They're looking at their child saying, I know that there's need that this person has that I can't secure for them in the community. And often there's a call to law enforcement or a call to the district attorney's office asking, well, what should we do next? This isn't what our beds are for. This isn't what our staff has the capacity to deal with. I should also say, and I think that Dana, the work that you did really demonstrated this very well. This is hard work to staff. A lot of the population that we're talking about, everyone is there to do this work because out of a place of care. But that doesn't mean you're not going to get hit in the mouth every now and then. Mm-hmm. It doesn't mean that you're not going to get cut up. It doesn't mean that there's not going to be some things that you're going to have to grapple with as someone who's in a position of care. And not everybody signs up for that. So with the circumstance with a lot of our children, it's even more aggravated because some of us are looking at those children and saying, these are kids who need care. And yet within the confines of a medical facility or hospital, because the challenge doesn't necessarily meet our definitions, it doesn't necessarily meet our legal definitions. These are people that often fall by the wayside, and yet we're going to see them come into our system because of what they're not receiving within our very confined definitions.
I wanted to talk a little, obviously there's a lot of emotion that goes into this, even though, and I find this so interesting having covered the criminal justice system of, it's a system that's perfectly designed to do what it does and it tries to take the emotion out of it, but these are people's lives here. We can talk about stats all day, we can talk about numbers, but there's a family behind every number that we talk about. Dana, I wanted to start with you. I mean, some of the folks that you interviewed for your series are no longer alive. And how do you navigate that as a reporter, that emotional tie? You can't help but have empathy for people. You can't help but, have just a basic human connection with people when they're telling such a gripping story. But you also have a job to do as a journalist. So I think people would be interested to hear about how you kind of process that and navigate that relationship.
So I've been a journalist for a long time, and I've sort of gotten a bit of a calloused inside a little bit, but it still hits you, right? And it still hits you. In this series, though, what I came to realize is that it's really part of the story. I mean, when you come across the third person in your series who's seriously mentally ill and a substance abuser and overdosed, you realize this is not a coincidence. This is part of the story.
And Richard, I'm curious from your point of view with the clients that you work with. I mean, it sounds like a lot of these stories unfortunately repeat itself, or they have a pattern to them. How do you work to stay engaged and, not numb out doing this type of work, for lack of a better word?
I think anybody who does this kind of work, you're going to have some. It's going to be a little bit of an emotional roller coaster. So I think there are some times when you do numb out, but there's a lot of successes. I mean, there have been. I can think of times when the folks that are here to my left, both I've worked with the DA's office and I've worked with the doctors and the folks at Central Regional Hospital, which is one of the state hospitals. And we've put together a plan, and there might be a conviction for a lesser charge, there might be a dismissal of the charge, but there's a plan for this person to have a home, and that person's never come back on my caseload. And every so often I'll look them up, they haven't returned. I don't know what's going on with them. I hope they're alive. But it was a success story at the time. But on a personal level, yes, it does affect you. I think there was a jailer on one of Dana's pieces who talked about how much this really affected her, and it does me as well. I think most of us try to find a way to clear our heads in a positive way outside the office to keep some perspective. And then just try to keep pushing the ball forward. Try to do the best you can for your clients, and there are those successes out there. There are plenty of successes out there. Sometimes I think we remember the ones we failed on more, perhaps.
I want to touch on two things. One is to Spencer's point about this being really hard work. So the vacancy rate at the state psychiatric hospitals has doubled in the last 3 years. If anybody is a nurse and wants a job, call me. Thousands of vacancies. Huge signing bonuses to try to get people. But we need recurring and stable funding to actually make those salaries competitive. This is important work. This is work where people develop a level of expertise over a lifetime and they invest in the next generation of those workers. You're dealing with the most complex psychiatric care. It is an art as much as it is a science, on the leading edge of science. And they do really good work to the point we have, treatment works. We have long-acting injectable drugs and antipsychotics now, and interventions for first episode psychosis, and a number of things that are just a marvel, but they're not widely accessible to people because of that issue. And I think that's my second big point I want to make here is that, we can see the pieces on the board. We have so many more tools available to us now. We have the right vision and the right order of operation to get things working. The problem is the will and the funding to get it done.
How much does the pandemic play into that? I mean, we saw, everywhere, especially in healthcare, of doctors, nurses rethinking their field if they wanted to stay. So, I mean, how much of the pandemic plays a role in the issue going on right now with staffing?
Well, first I want to thank my team, because most other psychiatric facilities in the Southeast closed their door as soon as COVID started. And we made the decision that we were going to continue to admit as much as possible through COVID with protection protocols, et cetera, recognizing that if that part of the system doesn't work, nothing works. But absolutely, no question, we had people that were far beyond eligible to retire who said, yeah, now's the time to go. We had lots of people who said, I can't do nursing anymore, this is too hard. And rebuilding that part of the workforce is a struggle that everybody in healthcare is dealing with right now.
So I definitely want to make sure we get time to talk about Medicaid expansion and solutions. So hopefully we're ending on a positive note. Earlier this year, Governor Roy Cooper signed legislation that would expand Medicaid, which is expected to provide health coverage to over 600,000 people across the state and bring billions in federal dollars to the state. But the expansion can't happen until a budget is passed, which is now expected to be maybe mid-July. So Dana, I'm going to start with you. If and when we pass Medicaid expansion, do all our problems go away? I mean, we've talked a lot about money this evening. Are dollars the answer?
Dollars are a big part of the answer, right? But and probably more than 50% of the answer. No, all the problems don't go away. And the reason is, and I've talked to people around the country that said, you know, we expanded Medicaid, but we hadn't built out capacity in our community. And so without the capacity, we're still struggling with some of these things. Things are better, but we're still struggling. And what I mean by, well, we've talked a little bit about it tonight of you know, we've got 600 staffed now beds in psychiatric hospitals, state psychiatric hospitals. Some decent percentage, and I don't know the number, but I would like to, but some decent percentage of those beds are occupied right now by people who are on the ready for discharge list, but who can't be discharged because there's no place in the community to send them. Why? Because we haven't been paying people enough to stay in the field, right? So if you don't have staff, in the hospital, you're also not having staff in the community. It's the same problem, it's just a different place. 44% of our kids who need psychiatric residential treatment facilities are shipped out of state. Why? We don't have the capacity. So it's very important to, as far as I understand, to also build capacity out. Now, the governor and the House have passed a bill basically that says, yeah, let me back up a little bit. So we're going to expand Medicaid at no cost to state taxpayers. I don't know if we've said that or we're clear about that, but 90% will be paid by the feds, 10% by the hospitals, but they'll be getting federal money to pay for some or all of that. In addition, because North Carolina has been so long in was refusing to expand Medicaid for so long, Congress in its COVID relief money said, okay, we're putting in a signing bonus. North Carolina and the other non-expansion states, if you expand now, North Carolina, you get $1.8 billion. Think of dollars from the ceiling, right? Hit the jackpot. $1.8 billion. There may even be more of that, which I won't get into right now. So the question is, how will that money be spent? And there are a lot of people who hope that $1 billion of it will be spent on mental health, including the governor and the House, as I was just mentioning. I'm also hearing some encouragement that on the Senate side, that there are putting some sought-for things into their budget. That some increases in Medicaid reimbursement rates might actually be in their actual budget. So we'll see. Whether we don't know whether it'll all be solved, but we'll see.
Cody, from your standpoint, what would Medicaid expansion do? What would it solve? Or would it solve anything?
Well, first, I'm going to compliment Dana. Usually I have to describe all that. You did beautiful. It's really, really well done. So Medicaid expansion is necessary but not sufficient, right? Getting everybody to have an insurance card is a good place to start. But I will describe some of the key aspects of the system that we need to build. But before I do that, if there's one takeaway here, it's that there is no perfect answer. There is no one thing. There is no huge focus. This is about an entire continuum of care where there is a lot of choice and a lot of opportunity to meet everybody wherever they are on their journey. Ideally, early intervention and prevention, but if much further down the path, as many opportunities to intercede and help them back into care. That's big concept one. The second big concept is that behavioral health is essential to health. When you go to the doctor because something's been hurting, my tooth's been hurting, they're going to look at it. They're maybe going to refer you. They've got a network of specialists they work with. Maybe they work for the same system. Maybe they're on the same EHR, and they're going to start to move you through the system. And then maybe they're going to send you for a certain test and send you somewhere to refer out, da-da-da-da-da-da. Where for mental health, if you have a mental health question, where do you start? Most people log online to find a provider directory. Why aren't you talking to your primary care provider about mental health? We have got to reintegrate these systems of care so that primary care, supported, funded, can actually begin to serve people. And mental illness is not a specialty thing. 1 in 5 people will have a mental illness in a given year. We've got to meet people where they go for healthcare and start from there. We can leverage telehealth to build out more access. We need more facilities in state, but we need more outpatient service as well. We need more ED diversion to support people in intensive in-home care. There's a lot of things. But the good news is that we have a lot of these resources sort of waiting in the wings, beds that are mothballed, capacity among providers that we have got to just light on fire with more support and more funding. And this is why I am excited about the governor's kind of visionary investment plan for $1 billion to really do the down payment on a system that's been underfunded for a long time. And I'm thrilled that the Senate in their draft budget said, we're going to increase behavioral health rates in North Carolina that haven't been increased in a decade. And I hope that that's a good dare to the private insurers who are paying woefully under as well. We've got to start on those things.
Mm-hmm. Spencer, when you hear the promise of Medicaid expansion, how does that sound to you? I think one thing that I think might be on a lot of people's minds is just holding those dollars accountable. How do we make sure that those are going to be spent in the right way?
I think that given the magnitude of the money that may be at our disposal, we have an opportunity to do something transformational. I remember being 25 years old and fresh out of law school, and before I got to the DA's office, I waited tables. And having to make the choice of spending $60 on a therapist every couple of weeks, or whether that was a luxury that maybe I couldn't afford. And if you're telling me that all of a sudden that investment can help someone receive a mental health diagnosis that they need, that can turn their life around, then all the better. And I wasn't necessarily poor. I had a job. There's a lot of people who don't have access to those resources and still have to make that decision about whether or not they should pursue mental health or whether it's a luxury. And I'm here to tell you, that is a dangerous decision to force upon people who live in your community, and it has repercussions that we see at our courthouse every day. So if you can invest that money and all of a sudden recognize that children could be receiving mental health diagnoses well before they end up in our juvenile justice system, if you understand that parents who all of a sudden have their own mental illness that they necessarily haven't dealt with, and it manifests itself in the types of trauma that their children are now exposed to because they're not getting the help that they need, if you can solve that, you also are making an investment in public safety and in our criminal justice system. That's an opportunity to do something transformational, and that's what I hope to see with that kind of investment.
Richard, I saw some head nodding as others have spoken, and I remember early back in the first part of the program, you talked a little bit about how some of your clients, when they get out of jail, they have to ration their medicine. They're doing the best that they can, or they have their 5-day supply, and then it's weeks before they could see a practitioner to get that prescription refilled. So from your point of view, what would Medicaid expansion, if it does go forward, what would it do?
Well, I don't know all the specifics of it, but if there were more clinics that were open where my clients could go and If they leave the jail, they have paper that shows they have a diagnosis. That is quite often transmitted to the local facility. They could get started on their meds much more quickly. They would break the cycle. Also, folks who are in the jail, our jail does a fantastic job with the limited resources they have. But if we had more doctors that were in the jail that could see the folks that were there, that would be incredible. One of the things that in looking over and getting ready for this that I saw is something like, depending on whose numbers you're looking at, somewhere between 20 to 50, 60% of the people in the jails have mental health problems, if not more than that. Those are folks that may need mental health meds. They quite often I'm having to call the jail to get my clients, say, look, this guy wants this medication. You guys dispense it. Can you get him in to see the doctor? If we had more doctors in the jail, people could get treated. They may not go downhill mentally. We might not have as many IVCs, involuntary commitments. We could return people back to society, function better. Just one number I will throw out. In Greensboro, I have a friend of mine who is the director of a local hospital in Greensboro, fairly large, and then I called and checked our jail. We have 250 beds in that one hospital. We have 800 beds in the jail. I think we may have 1 or 2 doctors in the jail. I don't know how many doctors they have in the hospital. It's a lot. If Medicaid expansion could put some people on the streets that could dispense medications and provide treatment and counseling to the people that need it the most, that would be great. If in the jails where we're seeing these crises that started this whole conversation, if we could get adequate mental health and treatment in the jails, that would be fantastic.
One of the things that we haven't touched on that I think is also really important for all of this to work is that we have to continue to work together to fight stigma. It's not just financing and availability of services as far as why people don't come forward for care. It's shame, it's the fear of being set aside, and it's particularly different between mental health and substance use disorder. All evidence looking around would make me believe that if I had a diagnosed substance use disorder on a piece of paper, I may struggle getting a job, right? We can't live in that world. We've got to recognize that these are diseases, that treatment works and recovery is possible, and we've got to try to give people the light to fight stigma. And I think that starts with us talking about our own experiences and being brave. And I think that's a good thing that came out of COVID. I think people experience anxiety and loneliness in a way that they've never felt before, and family members are talking about it in ways that we've never talked before. And I think we have to use that energy to really fuel a sense that mental health is just like talking about, well, I'm struggling with diabetes or I have a cancer diagnosis, and friends come to the house, they show up, they ask how they can help, they see if they can drive you to your appointment. When a kid gets committed to a facility, your neighbor checks in on you and sees what's going on, doesn't say, ooh, I don't know how to talk to them, what do I do? Because we really have to come together around these things. If we don't fight stigma, then we will not make progress.
Well, it sounds like Medicaid expansion is forthcoming, but Dana, it hasn't happened yet. From your reporting, what are the other solutions that are out there? I mean, likely Medicaid expansion will come through, but if it doesn't, or folks have to wait longer than anticipated, I mean, what would happen next?
Well, that's why you have to keep listening to the series, because we're getting to the solution
Nice
stories. But so one of the things we will look at is what's happening with the in-jail restoration pilot in Mecklenburg and the community restoration pilots. We are going to go, we have talked a little bit about the Chief Justice's task force on ACEs, and I think even though that task force is ending, it does seem like there's some move towards these safer baby courts, which sounds, from what I know, pretty exciting, that kids who are being exposed to trauma, perhaps of parents who are substance abusers or mentally ill, can be removed from the home while their parents get treatment. Certainly, but then we're also going to look at some other things that are being tried elsewhere. So.
Okay. Well, I don't want to give anything else away in the series, but I do want to, before we transition to the Q&A part of the evening, I did want to ask for your personal perspective from your reporting, if there were any solutions or there was any one voice that you heard throughout the course of this series, and as you continue to do it, that you thought, well, why isn't this being considered, or could this be a possibility?
Well, can I answer the question a little bit differently? Because one thing I was told by one person about that $1 billion was, well, they don't want to throw money at the problem. And I thought about that afterwards, and I thought, you know, through the course of this series, what I've tried to do is show the suffering that these people have, primarily by hearing some of their own voices, right? And hearing from their relatives. But one of the other themes that really doesn't come out from the series is how much we currently spend, how we are currently throwing money at the problem in a way that is not only not working, but I mean, it's ridiculous. As you know, I spent 12 years on the U.S. House Appropriations Committee, and I would have been outraged at some of what I see here. We spend you've told me, $1,400 a day on a state hospital bed, thereabouts. So going back to John, the guy who we started with, who's been 5 years without a trial, he'll probably have spent an entire year in a state hospital, given all his various iterations there. He'll spend a year. And then you've got the cost of him being in the jail. And so we'll have spent over $1 million on him to make him sicker. What have we done with that money? We've made him now where maybe he's going to always be a ward of the state. Congratulations. So I think we're throwing money at the problem. I mean, and I could tell you other, he's not alone in that. I mean, in Mr. Gill, who we haven't talked about, who's, I don't know if he ever had a chance, but that he went through 10, I don't know, psychiatric residential treatment facilities when he was a kid. Well, they clearly didn't help, and there's some evidence in the literature that they can be harmful if you put kids in with kids that are more violent than them. Well, there's a recent unpublished research that shows that we spend $100,000 a year per kid who are in PTRFs. I mean, this is just, we are throwing money at this problem. And so that is something, I wish there was a way of really going through and doing a real scrub and saying, this is how much we're spending on it not to solve the problem.
I so deeply appreciate this point, and I think it's a very simple concept. Think of any chronic disease, cardiovascular illness, right? How much does it cost for statins and blood pressure medicine every month to manage that risk factor? And how much does it cost to have, major cardiovascular surgery or treat a stroke, right? The thing is, with behavioral health, the system is currently designed and resourced only enough to keep people in a constant state of crisis at the most expensive point in the process. So the money that we need to spend is not about spending. It's about investing and trying to shift the paradigm of care to get more preventative and more upstream. And we're just talking about the money we're spending. Think about the opportunity cost, because the truth is that all these folks that ended up in jails, those are local county dollars. People that are experiencing homelessness, those are different dollars. Loss of taxpayers, impacts to family. These have real life and real financial losses on the other side of the equation too. This is a hugely penny-wise and pound-foolish situation. People can think $1 billion is a lot of money, and it is a lot of money, but relative to the losses and the money we're spending in other places, it's an amazing investment if we can begin to turn this thing around.
Well, I want to make sure, first, I want to say thank you to all of you for being here tonight. Thank you for your time. Let's give our guests a round of applause. And I want to make sure that we get a chance to hear from you all. If you have a question, we have Gabe and Greg. They have microphones, and they will walk up to you. If you can ask your question succinctly, and we'll turn it over to the panel to answer it. Does anyone have a question? You guys see? Raise your hand high. We'll go to Greg first.
I wanted to ask sort of a base question and then some embellishment of that from the panel. You mentioned that in North Carolina, private insurers pay less than in other states. Why is that? And how does that, and then the second broader question is related actually to everything else that's been discussed, including Medicaid and Medicaid dollars and so on. And how does that fit with the political mindset in the state, in the legislature in particular, which I see as obviously a critical point in the whole process of policymaking and funding for it?
I don't know why that is. I just know there's a Milliman report that comes out, that came out last in 2017, that found that relative to what they pay for physical health care, that private insurers in North Carolina pay disproportionately less than insurers in other states. And maybe someone else here knows.
Yeah, two thoughts on this. One is, legacy stigma. It's not been a priority. The second thing for everybody who is an employer is that, employers have to, most private insurance is really employer-sponsored insurance. And so employers build their benefit plans, and they have to say, I want you to provide behavioral health services at low or no copays. I want a network that looks like this. They have a lot of ability to shape that. And, over time, that has not been a priority. And so that's why employers play a particularly important role when it comes to private insurance to try to improve that. To your point on Medicaid expansion, I will say that I think it's actually been the conversation around behavioral health that has been one of the major reasons why we finally broke through on expansion. It has built a non-traditional coalition like none other. Dana knows, and some of you may have joined me, I've done 11 town halls across the state so far, and we're going to keep doing them, talking about mental health. We just did one in Cherokee a few days ago. And we always have Democrats, Republicans, local government, whoever. This issue brings people together across all bounds. And it's been phenomenal. And as is often the case, there's still disagreements on exactly what we should do when, but it's not falling in normal partisan conversations like things usually do, which is terrific.
Good afternoon. Dana, I first want to say thank you for giving a voice to the voiceless. I appreciate you for that. My question is, are you having deeper intentional conversations with folks who are in fact involved with prison ministry? I've been involved in prison ministry for 48 years of my life. And so some of the things you talked about is factual, some is not. Are you willing to have, to reimagine how this work needs to look in terms of ensuring that we save lives? Are we actually going to deal with the elephant in the room, which is race and racism? Not only around behavioral health and mental health, but simply the system as a whole, whether it's healthcare or incarceration. And are we, and I'm saying we as the village, we as the people in this room and those who couldn't make it tonight, willing to truly hash out how we deal with the intersectional harms to people prior to them becoming incarcerated, specifically Black and brown children who already have someone in some private entity looking very greedily to get them into that system. I think we need to really think about that, because many folks who are incarcerated who have mental and behavioral health may have gone into that system with some trauma, and later became mentally unstable. Some who've actually taken their lives. And this conversation is so needed, but I think we need to go much farther than we're going right now.
Well, I can so I think it was, someone help me, last week's story was on this very topic. The trauma, the intergenerational trauma that happens, and that even though mental illness and this trauma can be across racial and geographic lines, in fact, because poverty is traumatic, and homelessness is traumatic, and incarceration is traumatic, and those things are disproportionately affecting African Americans and other people of color, that therefore those kids tend to be more traumatized, or more like, probably more traumatized too, but also more likely to be traumatized. And so that's what this whole idea of the safer baby courts is about, is to try to get people care, but take the kids away while they're getting care, not take the kids away, take the kids out of the home while they're getting care, have them continue to interact with their children, have them to get parenting classes or family therapy or whatever to help them to reintegrate. And so that is something that I think the state is at least piloting now. And whether it gets funding is just a whole nother issue.
Anything anyone else on the panel would like to add to that point?
I'll just echo, I think the criminal justice system, I think we've come to recognize that it disproportionately affects people of color. Some of it socioeconomic, some of it racial. And I think anything that we can do to improve the system for mental health is going to help proportionally, probably, more people of color. Earlier on, when you were first asking your question, I think you asked something about, if I heard it correctly, the use of religious organizations that could help in this context. And I know that there are some rehabilitative programs that are in place in Guilford County that work with the jails that use that model and have helped people move out of the jail and into a more stable life. They're providing transitional housing and things such as this. I mean, I think those discussions are taking place. I mean, I don't see people putting their head in the sand on those issues anymore. And I'm relatively young. I've only been doing this work for about 22 years. But it doesn't look to me like people are putting their head in the sands on those issues. They're front and center most days, at least that I see in our courthouse.
So what I would add to it, and it's good to see you, is, first and foremost that Governor Cooper established a task force on reentry, as you are aware, and that task force has a large and diverse group of folks, and faith-based engaged folks are really key to that. I'm channeling my good friend who I've been traveling the state with, Senator Jim Bergen. He would say, I believe we need to heal people mind, body, and spirit. And that is a part of this, and we need to invest in that as a strategy. And so when Governor Cooper put $150 million as part of this $1 billion reinvestment plan for justice-involved populations, having all partners at the table is going to be the only way that we know that is going to work. The second thing I'll share is we have 3 priorities at the department. We have aligned all of our work to a document called Healthy North Carolina 2030. Look it up. And it's about 22 measures around population health that we're trying to drive and improve. And dismantling systemic racism is one of those measures. And I very much see the conversation we're having tonight. We talked about a lot of statistics about the disproportionate number of people in jail with substance use disorder. We also know that disproportionately that the folks that are in jail and prison are more than half people of color, when only 22% of the state is Black or African American. And so, when we have those sorts of disproportionate outcomes for folks, we've got to pull the thread all the way down to foster care and a number of other issues where these systems interact. So, a lot of our goals are aligned in that space, and we're eager to do it.
Mr. Mack, I didn't jump at your question because sometimes on issues of race, it's good to hear from the white folks first. And so thank you. I will tell you, you started your question by talking about the ways in which we can employ and use the perspective of those in prison ministries. And I'm not using the phrase too late, but I will say that there can be great impact by dealing with this issue, as we've discussed here, much earlier than by the time somebody ends up in prison. As an actor in the criminal justice system, we have certainly borne our fair share of scrutiny, rightfully, in how racial disparities play out every single day. The healthcare system has too, but I'm not necessarily sure that scrutiny has been as deep so that we are asking the question, like we mentioned earlier, about why it is that a black child is far less likely to have a mental health diagnosis before they reach the age of 8 than a white child is. That is an important question to wrap our arms around well before we get to the questions about the criminal justice system. Because it is my belief that as I look at files every day, and if I start digging into a juvenile history for a criminal defendant, that it's a high likelihood that for a black child or a black defendant, that I'm going to see a juvenile justice history that's going to give me a lot of information about someone's mental health background. And from a white defendant, I'm not going to see that juvenile justice history that's going to tell me that. I'm going to hear about it from his lawyer that's going to tell me about the mental engagement, their mental health engagement that they had from private practice. That is a difference. That is a tangible difference that we will see in how health disparities play out every day. It is important that we engage at the end of that river, but it's really important and really critical that we use this moment in dealing with health disparities and seeing how they manifest themselves in our criminal justice questions every day.
We'll go over here.
Hello, I'm Nate Carter. I'm a doctor psychiatrist at Novant and in the outpatient as well. A big problem we're seeing is with the explosion of opiate use, especially with fentanyl. Is there currently medication-assisted treatment for inmates? And also, how will the Medicaid expansion affect, access to medications like methadone or buprenorphine?
So I'll hit this quickly. So we currently have medication-assisted treatment programs in 40 of 100 counties in jails. We'd like to do it everywhere. But as you alluded to, the lack of insurance is a big issue. We spent $105 million to provide substance use, in particular MAT, for uninsured and underinsured North Carolinians last year. Does anybody want to guess how many people that served? I won't do my whole Price is Right thing. 35,000 people. It's a very expensive proposition. It is a lot of money. But again, this goes back to the investment concept. Medicaid expansion will cover that service, along with a number of other services that are part of supporting recovery. And then we can reinvest those $100 million in a lot of other things that aren't covered by insurance that we know are critical for recovery. And supporting other people that are interacted in this, people with disabilities, a number of other issues that often get interacted here.